Morning, everyone. Really appreciate everyone taking time from their lunch to join us today. I know folks are going to continue to trickle in from the back, but we're going to try to keep this on the shorter side and save some time for question and answer at the end. I'm Chetan Bedagauda. I'm a neurosurgeon at Johns Hopkins, and real pleasure to be conducting the seminar with the longtime friend and colleague Matthias Holdhoff, who's a medical oncologist also at Johns Hopkins. And for the next 50 minutes or so, just want to talk about the work that we've been doing academically, as well as some of the developments in the space from a number of groups around the country, around the world, including many in the audience. So really appreciate you all taking the time, and we can get the deck up. That'd be great. So this is a disclosure. The fine print here is sort of dictated by the university. I'm a faculty member at Johns Hopkins. I have intellectual property that's been licensed by Belay Diagnostics, which I have a board membership of. The data and the figures that you'll see today were constructed only in the academic setting and don't have a relationship with Belay. It's also important to note that the university also has a conflict of interest. So this is the disclosure. Happy to discuss this if people have questions. But to continue that disclosure, really can't cover everything in this space. We all know that the liquid biopsy space is rapidly increasing and burgeoning. Really today we're going to be focusing on one area, one small tidbit of this sort of mountain of knowledge that's being uncovered, and that's looking at tumor-derived DNA. And that sort of work has been ongoing in our lab group for about 15 years, right, Matthias? A decade and a half when we first started working together in the lab, both as postdoctoral fellows. And it started with this very simple question, how can we translate our genetic understanding of tumors to improve patient outcomes? And this has really been driving all the work in our laboratory group for the last decade and a half. And today we'll talk about one aspect of the research in our group, which is circulating tumor DNA and largely in the space of cerebrospinal fluid. And most, if not all in the audience are familiar with this. These are quantitative biomarkers that track longitudinally with time. And there are a lot of exciting different areas here. We know that proteins, RNA, DNA, methylation, mutation, microvesicles, circulating tumor cells, all of these have important and exciting developments in the field. But today we're really going to talk about one, which is tumor-derived DNA. Oncologists in the group here, people who take care of folks who have cancer, don't need an introduction to cancer biomarkers. We use this clinically every day. Things like PSA, Hemocult CA, these are the standard biomarkers. Really, I think the field is driving towards a different genre, a different type, and these are using things that actually drive the cancer process, fundamental to the pathogenesis of neoplasia. And the area that we're interested in is these driver gene mutations. And so this to be differentiated from tumor cells, which are another important biomarker in oncology. These molecules of DNA are shed by both cancer and normal cells as they replicate and turn over. They tend to be shed into blood as well as other ancillary fluids, which we'll see in a few minutes. And they tend to be small and abundant, and the biggest source of these is the normal cells within an individual. Our group has really been focused on using mutation-based analyses because we think there are specific and could be present in almost all cancerous conditions. The challenge has been the proverbial needle in the haystack, and so our group has spent an extraordinary amount of time looking at this technologically, as have many in the audience. The needle here is the tumor DNA, the hay is the non-tumor DNA, and really the technologies have been burgeoning over the last 15 years, 20 years, because we knew that quantitative or semi-quantitative PCR is not going to cut it. It's just not sensitive enough. We need things that go well below the threshold of 1% to detect these rare variants. And both Matthias and I had the privilege of training with Bert Vogelstein and Ken Kinsler, who published this paper at the turn of the century looking at digital genomics. And what does that mean? It means really something very simple. For those who are in the next generation sequencing space, this is an example. It means uniquely identifying a molecule of DNA and understanding if it's wild type or a mutant at a particular position, and then actually quantifying it, literally counting individual molecules to see what their status is. This work began in earnest by a very talented MD PhD student, Isaac Kinde, several years ago. He published one of the early detection strategies called Safe Sequencing System. We won't belabor the technology today unless people have questions, happy to go into it, but this was one of the early developments in the space to be able to barcode uniquely each molecule of DNA, redundantly sequence it, and identify if that molecule of DNA had a mutation or was wild type. So many years ago, we embarked upon this journey by asking a very simple question, which is, can we detect tumor DNA in a variety of tumor types? And we looked at 400 or so cases. The majority of these are not involving the central nervous system. The study design was very simple. We took patients' tumors, we sequenced it, we identified mutations within the DNA, and we asked whether we could identify those same mutations in the corresponding plasma. And we ended up with a figure that looked something like this. There were certain tumor types like colorectal, bladder that were readily detected, which are on the left-hand side of the screen, and then our gliomas, that box somehow got misplaced, is on the far right-hand side of the screen. And to our sort of dismay, we started thinking about alternatives, and one of those alternatives that's been well recognized is that we know that cancers and tumors shed into ancillary biofluids. And this is not new. This has been known for decades. We do this clinically when we send folks for stool-based testing or cervical cancer screening. And so we asked, how can we use this for benefit for our CNS cancer patients? And the obvious choice for us was cerebrospinal fluid. And we know that there are challenges with cerebrospinal fluid, that it's not as easy to access as sputum or urine or even blood. But sometimes the challenges may be, in our minds, a bit overstated. So this is a very interesting paper published by Adrian Bohr and the colleagues at MSK, which asked patients who were having a lumbar puncture what they thought it would entail. And so the pre-LP survey suggested that physicians thought it was actually going to hurt more than patients. And when you asked the patients after they had the LP, actually 50% or so said they had minimal or no pain at all. And when you asked them if they would have a second LP, about 80% said yes, and about 2% said no. And 20% in the middle were unsure and would need more information. So while LPs and spinal fluid sampling is not easy, perhaps we as clinicians or folks in the medical profession overstate or overthink how invasive or how uncomfortable this might be. One of the early papers in this field was published by Melanie Gephardt and colleagues at Stanford. She described a case report using droplet digital PCR of an individual who had a melanoma, leptomeningeal metastasis, had 9 sequential time points, and you can see beautifully that the tumor-derived DNA levels track longitudinally in time. Patient becomes asymptomatic at 2 months out. And as we are all aware, with leptomeningeal disease, almost always there's recurrence of symptoms, which corresponds to the mutant allele fraction in the cell-free DNA in the CSF. And when she tested it in the plasma, it was not detectable in this patient who had brain metastases and leptomeningeal dissemination. So using the literature in our own cohort, we looked at a cohort of around 30 different patients, and these are primary tumors of the brain and spinal cord. I know the font is small, and this was a summary of that. We really saw that about 3/4 of the cases had detectable level of mutations. This was using a personalized bespoke approach where we knew the tumor mutation ahead of time, and we tested the corresponding CSF. We'll show you in a few slides where a tumor agnostic approach could look like. And in terms of the malignant brain tumors, the grade 3 and 4 tumors, we were able to detect almost all of them. This work has obviously been accelerated by many investigators in the field. This was a beautiful paper by the Memorial Sloan Kettering Group and Alex Miller, published in Nature, looking at a LP that really can give a genotype that looks very much like tumor tissue testing, positive in about 50% of cases. And so we thought, gosh, there is a lot of work being done here. Can we develop a biomarker that really can be universally applied without any a priori knowledge of cancer biomarkers? And we thought about the ways of incorporating chromosomal copy number changes or aneuploidy, which is a hallmark of almost all cancers. And Chris Duvall, who's an assistant professor at Hopkins, really came up with this very clever technology, which entails a very simple assay. It harnesses the power of the repeat elements throughout the genome. So a single primer pair is used to amplify 350,000 genomic regions throughout the human genome. And we look throughout to see if there are allelic imbalances. And he applied this to a cohort of CSF samples from individuals who had brain metastases, glioblastoma, CNS lymphoma, and medulloblastoma. And he was looking for gains or losses of chromosomes as well as focal amplifications. And he had two cohorts of patients, about 300 in total, 90 or so in the training and 190 in the validation. And you can see the breakdown of the cases. And what he did initially was to set a threshold that would be called positive in the cancers and negative in the controls. And then he employed that threshold and sort of evaluated the CSF samples. And what he was able to see was not only large deletions and gains, but also these sort of small subchromosomal alterations in canonical cancer genes. And what he found was that, number one, that this assay could be used very specifically, not found in the non-cancer patients, but found in a large proportion of the cancer cases, and that it outperformed cytology and that CSF was more sensitive than plasma, at least in our hands. And this is the summary of that study that Chris published, where the performance is reasonable, certainly better than the 10 or 15% we saw in the plasma early on, looking at somatic mutations, but we knew we could do better. We knew there are certain cancer types that were not as well detected. And so that's where we thought about other alternatives. And I think this is something that the field really has embraced in multiple different cancers. And this is looking at more than one analyte. You know, the first study we showed looked at just mutations. The second set of studies looked at just aneuploidy. And now we're thinking about how can we combine things in a streamlined workflow. And this is a technology that is called Safer Sequencing System, which really uses duplex sequencing. So using both the Watson and Crick strands to identify a true mutation and separate it from the experimental background. And you can see that when you get to low levels of mutation frequency, much less than 1%, there's a lot of spurious background that you can see without sort of a duplex approach. And when employing a duplex approach, sort of the background can fall away, and the sensitivity can be driven well below 0.01 or 0.001%. And this is sort of magnified here when you think about the levels of detection. You're thinking about very, very infrequent events that are now being detected. So we took this approach, and these are unpublished data that we hope to disseminate later this summer, but really looking at a panel of 121 amplicons of the most common cancer driver genes of both brain mets and primary tumors of the brain. They underwent whole genome sequencing for copy number changes and then somatic mutations in these 121 amplicons, and really using 2 mLs of whole CSF. And this is sort of the types of copy number changes we're able to see again with this workflow. And this is the sort of overview slide, and I'll just skip straight to the summary statistics. And so, you know, with just aneuploidy alone, we were seeing sometimes 70 or 80% of the tumors being detected, and then when you add in the mutation panel, you can really boost the sensitivities to around 90% for the 4 major categories that we've been commonly testing. But we certainly don't think this is the end. We think this is just still the beginning of the road, and we think that incorporating additional analytes, you know, methylation, tumor microenvironment, i.e. immune system related markers, as well as others that many in the field and audience are studying, including RNA, protein, and microvesicles, really has a lot of power and potential. And what we hope to show, again, in our upcoming publication is an application of this technology, which allows methylation, mutation, and copy number changes to be unified with one workflow from about 2 mLs of CSF to, again, try to amplify the signal, amplify the information that we can give back to patients, their families, and their treating clinical team. When we think about biomarkers in general and technology more broadly, especially in the medical arena, one of the questions is how do we get uptake? And this is a complex challenge, and there's been sort of some early papers looking at this in the liquid biopsy space, and some of this work has been led by Lauren Lehman, who some of you may have worked with or know from BloodPack, and wonderful work thinking about how do we get equitable and widespread access to care in liquid biopsy specifically. The current state is highlighted here on the left, which is still in the developmental stage, not impacting health disparities, and really, hard to know how much this is helping our patients on a day-to-day basis. When we get to limited adoption, we think we can help a certain subset of the population, but the goal here really is to use technology to get broad adoption, to be able to not only increase access to care, but also decrease health disparities. And so how could this look? And so a couple of slides here on this topic before I turn it over to Matthias. Part of the challenge is we see this when we talk to our patients, right? The lexicon, the jargon, the verbiage used to talk about genetics and cancer biology is complex. It's complex for us in the field, it's more complex for families. And this is a survey looking at patients who were talking about tumor tissue, not even liquid biopsies, tumor tissue sequencing, which has been around for years. And they asked patients and their families, how commonly do you understand the terms being used? When we look at one of the columns or terms, which is gene or DNA, we have 40% of folks who don't understand the term gene, 20% who don't understand the term DNA. And so when you think about how do you get a technology in place when we still need to sort of educate our patients, this is some things that we need to think about when we're deploying technologies such as liquid biopsy. And so there are studies and papers out there. Are we going to just develop technology and it's going to be too early now, and then we wait so long it's going to be too late? And so this study looked at 41 different surveys from individuals in the medical field, a variety of cancer specialists. What you can see here, you don't need to see the fine print, is that really there's no agreement about the priority. So if we were to survey the audience here, we'd probably get something similar to this. What is it that we need as a field to implement this technology? What are the barriers to get there? So no real agreement in the field. And so one of the things that did arise from this is that there's reluctance of physician use. That's one of the concerns, that people like us in the audience may not want to use this because it impacts our own careers in ways that may be deleterious or detrimental. We've seen this with other technologies and other specialties. And so I have a particular interest in this because as a surgeon, one of the procedures we do is a needle biopsy. Many in the audience, if not all, are familiar with this. It's a small opening in the skull. We pass a needle under MRI guidance and we sample tissue purely for diagnosis. Zero therapeutic benefit. I will tell you from personal experience, one of the least satisfying procedures to offer a patient. Why is that? Because these are not trivial. We call them minimally invasive surgeries, but come with real risk. Mortality after biopsy is 3%. So we're trying to get a diagnosis, and in the end, we harm patients, and that's troublesome for us. Other things, non-diagnostic biopsies. This particular paper cited a 17% rate. One of the most challenging conversations I have with the patient is after I've done surgery for them, tell them the pathology is non-conclusive, and we may have to go back in. And this is not just because we're poor surgeons or poor technique or less experienced institution or bad pathology. This is the literature over and over. And so when you think about pathology testing, we want to get enough tissue to be able to do advanced testing. And in this study, 29 of 39 high-grade gliomas underwent molecular testing. So we know that the tissue is scant and oftentimes insufficient for molecular testing, and almost certainly insufficient to allow patients to enroll in tissue-based clinical trials that need advanced testing. You compound this problem with access to neurosurgeons with the fact that really neuropathology and neuro-oncology is a shortage, and this is expected to worsen. So can we think about using technologies like liquid biopsies to address this growing need? And that's what Lauren Lehman was talking about in her paper. Get broad adoption of technologies. Initially, you may think this is a barrier to care, but if we can democratize it and make it accessible and feasible and affordable, perhaps we can actually move the needle and increase and decrease the variance in care. So these are all technologies that are complementary. We're not thinking that one is superior to the other. And when we think about the distribution, and this is for neurosurgeons in America, where the darker colors are more highly represented, but you can see there are a lot of light-colored areas where there are very few. But you can overlay the U.S. map with neuropathology, neuro-oncology, radiation oncology, and it's going to look very similar. So perhaps this is an opportunity for us as a field to think about technologies that not only can improve our insight into the biology of cancer, introduce areas of us being able to understand disease progression or diagnosis, add to our ability in our clinical armamentarium, but also perhaps find a way to decrease the variance of care of our cancer patients across the country and hopefully improve outcomes. So I'll pause with this conclusion slide and allow Matthias to take over. It really has been an amazing avalanche of information when it comes to genetics of brain tumors and brain cancers, both primary and metastatic. A lot of enthusiasm in the liquid biopsy space, both within neuro-oncology and medical oncology in general. We think that really prospective studies to bring this in a collaborative way, looking at multiple analytes, is ultimately going to be the best for our patients. Thank you very much.
So every lunch meeting has a dessert, and every talk should also have a dessert. So the next talk is going to be your dessert. So I'm going to focus on the potential clinical use of CSF tumor DNA in cancers of the CNS. And as Jason mentioned, we are partners in crime. We both work at Hopkins. I'm a medical oncologist, neuro-oncologist by training. I have a couple of disclosures. And I'm going to briefly lead you to how we got here, that we now have so many amazing tools we're trying to implement into clinical practice. I will talk about the potential clinical applications for CSF tumor DNA in patients with these cancers and barriers for clinical implementation, and we might have time for discussion and some Q&A in the end. So as Chetan mentioned, everything started with the idea of identifying and measuring and quantifying individual mutations in patients. So this digital PCR, DNA fragment, being mutant or not mutant, counting these. There were some tedious initial technologies that were done in part in the lab, one of them called beaming, focusing on individual mutations by patients initially identified in tissue. On the right side, you can see one of the earlier papers where you could, for the first time, really monitor dynamic changes in tumor burden in colorectal cancer. Then came the introduction of next-generation sequencing studies and the opportunity for a disease-agnostic approach with more and more refined technologies. So there was a lot of progress in tumors that are systemic cancers, especially colorectal cancer, lung cancer, breast cancer, and circulating tumor DNA that is blood-based is in part already used outside of clinical trials. And these studies are being integrated into clinical trials. But these are systemic cancers. This is an example here of a potential role of circulating tumor DNA to decide on the potential benefit of adjuvant chemotherapy in stage 2 colorectal cancer. So this was super exciting. However, we are working in the field of brain cancer. We are brain people, and for us, nothing really seemed to work that well. And this is the figure that you saw before. Unfortunately, in glioblastoma, we saw only a small fraction of patients that had detectable circulating tumor DNA in plasma. So after multiple discussions and also a lot of skepticism that was voiced, can we really do this? Can we not do this? In patients, there was the shift towards circulating tumor DNA. And now, as Jason put out really nicely, we have a bulk of really good preliminary data using circulating tumor DNA from CSF. So this is where we are. We have all these tools, we have all these questions, and for clinical investigators, for people in the lab, for translation investigators, this is really, really cool. There are a lot of trials you can do, a lot of studies you can do. And so how can we apply this for clinical use. I'm going to separate or subdivide my talk into some comments about diagnosis, staging, disease monitoring, and early detection of treatment failure or response and evolving mutational changes. And along the way, some comments on minimal residual disease. So there has been a growing knowledge about the complexity of cancers of the central nervous system. And there have been several updates of the World Health Organization's classification. And I think the person who put this best into one figure is Craig Horbinski, our friend from neuropathology at Northwestern University. I think it's this, sort of like the PSA equivalent of how we have a rising titer of more and more diagnosis to differentiate. It's an impressive number of molecular findings and new knowledge that is now put together in this classification. This also requires more fine-tuned understanding and clinical testing that we need to implement into clinical practice. So what is the utility of these tests in diagnosis of cancers of the CNS? So certainly there are tumors that are difficult to access surgically and where a biopsy carries significant risk. There are also situations where obtaining cerebrospinal fluid is already part of standard of care, and having a more sensitive and more specific test will improve the value of the CSF sampling for the patients. What about leptomeningeal disease, suspected leptomeningeal disease, molecular diagnosis with this approach? What about brain metastases? What about primary and secondary CNS lymphoma? And certainly patients that are not good surgical candidates, elderly or frail patients, patients that are high-risk surgical candidates. And sometimes we just want to know, is this actually a cancer or is it not a cancer? Just very simple questions that can sometimes help us, and some technologies can be of great value. So a special challenge are brainstem lesions, and we know this from our tumor boards, and as you all know, these tumors often lead to a discussion about, is there a need for a biopsy, can we treat without biopsy, and a differentiation about tumor or not tumor, or what type of glioma this might be with a liquid biomarker could be really, really impactful. So midline gliomas are a diverse group of tumors, as you all know, that have been identified and reflected in one of the more recent WHO classifications. There are diffuse midline gliomas, but also other tumors with different mutational makeup. That is associated with different clinical features and also different outcome. And so I'm using the example of midline gliomas as a paradigm to show how circulating tumor DNA could be used in this clinical setting. So this is a patient where you can see this faint T2 change here. And this was actually a real patient at Hopkins. And before the 2016 classification, this patient had a biopsy that was inconclusive. And so there was a repeat biopsy done. And at that time, there was the knowledge about the subgroup of the H3K27 mutant patients. This was immunohistochemistry, but the diagnosis could be made. So this was a big improvement. And now we have next generation sequencing. So we are getting into really like significant short-term improvement in the diagnosis of these tumors. So these tumors can have different locations. They can certainly be detected depending on the location in CSF. There was a study here in the Acta Neuropathologica using a targeted panel of 68 genes with overall really good detection that illustrated that with liquid biopsy you can actually find a quite significant molecular diagnostic characterization of the tumors as compared to tissue analysis. So you can see here on this example that there are both the liquid and the solid tumors quite similar in their features. So there was an excellent study published in neuro-oncology that illustrates the tracking of response and progression in patients with diffuse midline glioma when they were treated with ONC201, which is a DRD2 antagonist. This study included serial lumbar punctures, and the data were really interesting, and they were proof of concept that you can indeed monitor with liquid biopsy a reduction in specific tumor DNA in CSF, and this also has implications for progression-free survival. Interestingly, there was also a signal noticed in plasma, not as strong as in CSF, so that was also noteworthy, but you could again see that CSF was superior to plasma analysis. What about lymphoma, suspected primary central nervous system lymphoma? The current gold standard is still a neurosurgical biopsy, and we still use lumbar puncture and CSF analysis, cytology, and flow, but sensitivity is certainly suboptimal, and very rarely we can really make a diagnosis without a neurosurgical biopsy. There are lymphoma-specific genomic alterations. So the question is, would you use a disease-agnostic panel? You use a targeted panel, but certainly now we have opportunities to study this. And there was a recent publication of the RANO working group and liquid biopsy that is really worth reviewing and reading, summarizing the data we have thus far on ctDNA analysis and clinical implementation in CNS lymphoma. The initial studies for diagnostic purposes show that CSF was again superior to plasma for diagnosis. What about staging of select CNS tumors? So I'm going to give a couple of examples: medulloblastoma, ependymoma, intracranial germ cell tumor, pineal tumors, and others, and as well as systemic lymphomas, where the question is, could there be CNS involvement of these tumors? Could this be reflected in reevaluation of the extent of radiation, which might have clinical impact? And certainly the question of choice of systemic therapy for patients with systemic lymphoma, with the question of whether or not to involve CNS prophylaxis or coverage. So medulloblastoma is an excellent example of where circulating tumor DNA from CSF can help with the molecular subclassification, but where it can also be used after completion of treatment to detect minimal residual disease. On the right side, in the survival curve, you can see on the blue line patients with undetectable CSF tumor DNA versus detectable CSF tumor DNA. What about systemic lymphoma? There are subtypes of lymphoma where CSF prophylaxis, although controversial, is still part of the clinical paradigm. And as an example, Burkitt's lymphoma, we use an international prognostic index, who should get CNS prophylaxis, who should not, and a highly sensitive CSF-based assay might really be superior to this. Of course, this needs to be prospectively validated. What about mutational heterogeneity and evolution of resistance in these tumors? And especially in some systemic cancers with brain metastases or also leptomeningeal disease. This is an example of a lung adenocarcinoma that developed a resistant clone, and this could be detected with CSF analysis, part of the really seminal study by Elena Pensova and colleagues at Memorial Sloan Kettering. And I think super exciting. So what about monitoring tumor burden and finding out whether we can detect resistance in other cancers and cancers of the CNS? A couple of examples why this might play a role are BRAF mutated cancers, also IDH mutant gliomas, very interesting now in the context of IDH inhibitors and other IDH targeted approaches, and again the diffuse midline gliomas, ONC201 being one of the treatments that are being developed. So can we do better than imaging? And we have some examples where we can illustrate this. So this is a patient that showed, based on the liquid biopsy, as shown at the bottom of this figure, that the test actually preceded the resolution on imaging of this lesion in the cord, so we could detect response earlier than actually imaging. On the other side, could we detect disease earlier or progression earlier than with imaging? And this is an example of a patient with leptomeningeal disease. Testing was positive in the absence of radiographic findings. And the holy grail for us in clinical practice is how do we differentiate pseudoprogression from progression? For those who are not neuro-oncologists, so after radiation and chemotherapy, we often see changes on MRI. And as long as these are within the radiation treatment field, these could very well represent treatment changes, potentially radiation necrosis, and not necessarily active tumor. If we could find out, is this indeed active tumor, then we would switch treatment. If it's not tumor, if it's just scar tissue, we would hold the course. So could liquid biopsy be used for this? So in theory, if we had a baseline tumor DNA level prior to treatment, it would go down and at some point would go back up. And if that correlated with imaging or even without imaging, could this mean that there's progression? On the other side, if the level stays down and the MRI looks concerning, could this mean it's pseudoprogression? So again, a lot of validation needs to be done. But this is an example from the clinic where a patient went for repeat surgery, and the question was, is this tumor or not? Pathology was consistent with pseudoprogression treatment effect, and the molecular test, the liquid biopsy, was also negative. So this could be further developed and will take a lot of work, a lot of effort, multi-institutional commitment to answer this question, but it could be really translatable. Can this marker be predictive? Can it be used for survival outcomes? And these are patients with glioblastoma that were tested at time of progression. These were CSF specimen taken at the time of the surgery, and you can see that detected versus undetectable levels correlated with outcome, progression-free survival, and overall survival. So this test was an aneuploidy-based assay, also that needs to be further validated in this setting. So what are the clinical barriers and the practical barriers for implementation? And Jason alluded to some of these already. We have a lot of data, but these are all small, for the most part, small cohorts, often single institution. We have no randomized controlled trials. We need more prospective validation. LPs are not the most convenient thing for patients, but if this could bypass the need, obviate the need for a surgery, this might be quite appealing. We have to keep in mind that not all patients are candidates for an LP. It's not safe in every patient. And we only have limited time points if we really do repeat lumbar punctures that we can use for analysis. And last but not least, these tests are not cheap. And the question is, will insurance actually cover these? A couple of considerations. It would be really helpful if these biomarkers could be integrated into clinical trials as a correlative marker. This is done fairly commonly now in solid tumors that are systemic cancers. So if we could do this with CSF, that would be really super swell. What about placing an Ommaya reservoir? Without really clinically actionable interventions that are available, this is not very appealing. However, if an Ommaya would allow us to better monitor disease evolution and potentially minimal residual disease, I think patients would be quite willing to have an Ommaya placed. And certainly it needs to be cost effective, and so we need prospective studies to really validate this concept. And this is one example where we have a collaboration It's called the Breakthrough Cancer Initiative. It's 5 institutions, 4 clinical institutions with an oncolytic virus based approach. A part of the companion diagnostics is the longitudinal sampling of CSF from these patients. This is just one example of how this could be integrated. I think more studies will follow that will be opportunities for this approach. So we have, in this case, we're actually using an Ommaya reservoir, and this is comes in quite handy actually clinically, and is of minimal concern to patients. In summary, we have had significant progress over the last 10 years, certainly over the last 20 years. We have highly sensitive assays, and there will be more that are coming down the pipeline. We have opportunities of an agnostic approach, getting the fluid, see what we find, not necessarily always needing to get tissue with surgery. And we need to translate this into clinical trials and prospective data. This is the neuro-oncology community, how I see it. This is all of us. So we're all working on the same thing. We're all pretty similar and very busy. And some people turn out to be a little bit larger and have a lot of gilet royale or grants. And we're getting together, and we are trying to solve these problems. So with this, I thank you, and I hope we'll have maybe a little time for a couple of questions.
So quiet in here. Have you thought, especially with some of your partners, about using this for things like NF patients and their risk of MPNST and gliomas or other high-risk syndromes parallel to what's done in colon cancer and Lynch patients? Because I can certainly imagine that for like leafra-many, and I mean the NF patients I think we all worry about so much, the gliomas and MPNSTs, and for the MPNSTs our imaging is still pretty limited. So have you tried doing that or working on it at all?
Great question. Indeed, that's an area that is of interest to both of us. We're fortunate to have a really strong set of collaborators in the NF space and MPNST specifically at Hopkins. And recently there have been a couple of papers, including one from our group, that's really looked at this because there is genetic differences between an MPNST and sort of neurofibromas, plexiforms, et cetera. And so one can sort of take advantage of that to try to identify an incipient MPNST. Again, I think the challenge is going to be rare entity, needs collaborative work to prospectively follow a cohort of individuals. Only a small subset, as you know, will ever develop the malignancy, but I think developing a framework to begin such a NF population-based prospective study would be super exciting, absolutely. And as it would be for other high-risk genetic syndromes for other high-risk patients and their families. Absolutely. Great
Thanks.
question.
I mean, there's already a network of NF centers, and I know UW would love to help if we can.
Absolutely. Thank you.
Thank you so much. I have a question about basically, like when we look at the tumor DNA in the CSF, is there a specific cut point when I look at this result to tell me, first, does it mean I have leptomeningeal disease? And is there any difference if I'm dealing with primary brain tumor versus metastatic disease? Is there also different interpreting like those results? Just wondering if there's any update about this particular issue.
Great question. And this is, you know, the challenge that's coming into the liquid biopsy space is really we're capturing information from multiple potential sources. And so is it a primary cancer? Is it a metastatic cancer? Is it leptomeningeal? Could we be dealing with that rare scenario where a person has two simultaneous malignancies, one systemic, one within the CNS? And so this is something that's plaguing the liquid biopsy field. I think there are a couple of things that we've thought about. I think number one is that often the genetics will help provide clues as to whether it's a primary or secondary tumor. It's not pathognomonic always, but certainly seeing an H3.3 mutation or IDH certainly gives credence that this is going to be a primary tumor as opposed to metastatic. And we also have to keep in mind, when we talk about these results, much like I did today, we just look at the liquid biopsy results. We haven't yet gotten to a point where we're integrating it with imaging, clinical decision-making as a whole. So I think in general, being able to take the patient's entire picture and adding a liquid biopsy result within that complex sort of milieu of information, social history, past medical history, et cetera, often can help resolve some of the sort of diagnostic dilemma. The challenge is when we do these retrospective or even small prospective studies, we haven't matured as a field yet to be able to integrate all those variables. But I suspect that if we were given it in a true clinical scenario, some of those questions could be resolved with just what we do as clinicians.
Thank you. Just a quick follow-up question. In the setting, let's assume we are dealing with glioblastoma and we are looking at those CSF. If we found a tumor DNA in the CSF, does it mean that the GBM has disseminated to the CSF, or has just it's a way to tell us that this is just the patient have a GBM? Just wondering if also looked into this.
Yeah, sorry, Matthias, maybe I'm hogging the airspace here. I'll let you take this one.
So I think, especially in glioblastoma, where we have a significant disruption of the tumor vasculature, tumor blood-brain barrier, liquor-brain barrier, we would expect to find circulating tumor DNA. I think that one of the key questions is still, what if we find some residual tumor DNA, but there's truly no really active disease. I think GBM especially is a very tough one, because we will always find some active tumor, even if we have. I think even if we had no detectable tumor DNA, we would always suspect that there is some tumor there. So I think I don't know if you answered your question appropriately, but I think there's probably other tumors where this would be more useful.
No, thank you. That's very helpful. You answered my question.
I also have some diagnostic questions if you've thought about it. One is for traumatic TAPS. Like, how traumatic does something have to be to just be contamination from peripheral blood? And then the second question is for someone with pachymeningeal thickening involvement. How likely is it that we're contaminating the sample?
Yeah, excellent questions. I may kindly ask for a repeat of the second one. I didn't hear the end of it, but the first question is a very good one, which is, if you have contamination from a spinal tap that's bloody or traumatic, does that impact the interpretation of the test? I think it depends on the clinical scenario. I think in someone who has a history of widely disseminated metastatic cancer, absolutely. I think certainly you can. I think even the bloodiest of taps, you're still only introducing, a few, if you're taking 2 mLs of CSF, presumably it's less than 50% of it is coming from the blood. So even if you assume it's 1 ml of blood, even the most sensitive of liquid biopsy assays for systemic cancers requires 5, 8, 10 mLs of plasma to be able to identify with certainty the ctDNA. Is it possible that 200 microliters, 500 microliters, 1,000 microliters of blood could give us a spurious result? It certainly is possible. I think this is where understanding that clinical disease state would be important. If that person has widely disseminated cancer, see a bloody tap, perhaps worth repeating that test to confirm the findings, but certainly an important clinical consideration. May you kindly repeat the second question?
Yeah. The second question was for somebody with pachymeningeal involvement of tumor. Just by virtue of sticking the needle through and into the CSF, would that have a different signal? I know with blood you should have a lot more background noise, so maybe there's a way to, do some quality check for the first question, but what about pachymeningeal involvement?
Yeah, so I think you mentioned if you literally stick the needle straight through like a micromet, right? I think that could certainly lead to additional shedding. But I think if you have that much tumor to begin with, then I think the diagnosis is probably already established.
It's already there, or it's going to be very soon, probably.
That's right.
Yeah. Thank you.
So any other questions? Otherwise, I thank everybody for... yes.
This is very practical question, but when you do the LP, do you usually use 21 gauge or 23 gauge? Do you have any recommendation of the thickness of the needle? Because I feel like when you use 23 gauges of the needle, like it may damage the DNA, but I don't know, like, do you have any recommendation for that?
Yeah, great question. So we typically go for the smaller gauge in our clinics, the 23 gauge needles. The approaches we've taken are a little bit different than what other groups have done. We actually isolate DNA from the entire volume of CSF. We don't spin it down to extract only the cell-free component. So if a 23 gauge needle is actually injuring some of the white cells or some of the cells within the CSF, it actually works okay for our assay. But for patient comfort and perhaps a slightly lower risk for post-spinal tap headaches, we often err for the smaller gauge needle, and we have not seen in our hands a big dependency on outcome based on that.
Thank you so much.
Thank you. Other questions? If not, I'll let Matthias have the final word here.
So yeah, I will have another final word. Well, thank you very much. If there are no further questions, then we thank you everybody for coming, and this is exciting. We're looking forward to work together.